Good morning, everybody. Today I will discuss the remaining part of my last video on headache. The tuberculosis and fungal meningitis may present important diagnostic and treatment challenges. They may often have a subacute presentation. Cerebrospinal fluid culture results may be delayed and microscopic inspection of the spinal fluid sediment may be non-diagnostic. When available, the polymerase reaction chain, that is PCR, this test can identify infected pathogens quickly. However, once the CSF is obtained for analysis, the best approach often is to begin the appropriate antibiotic treatment immediately to minimize the risk of such catastrophic complications such as brain infarcts, hydrocephalus, and infection masses. Dissection of a craniocervical artery may cause neck or ipsilateral head pain. When there is sufficient association of ischemia, the affected brain regions are often transiently dysfunctional or it is infected. Often the internal carotid dissections cause burning or pulsatile pain in the ipsilateral neck or periorbital nose, jaw, or frontal regions of the head. Most patients have an ipsilateral Horner syndrome. Usually, pain from a vertebral artery dissection is in the neck or occiput. High velocity rotational manipulation of the neck may trigger vertebral artery dissections. When the dissections are of the internal carotid or vertebral arteries are suspected, then an MRA, or if that is inadequate or unavailable, conventional arteriography is warranted. If a dissection is documented, then initial treatment including anticoagulation and cautious normalization of blood pressure. Malignant hypertension with papilledema may be associated with severe headache and warrants immediate treatment. However, it should be emphasized that moderate hypertension is a very unlikely cause of headache and other etiologies that should be sought. Acute angle closure glaucoma can cause intense eye pain of rapid onset. Carbon monoxide poisoning is associated with headache. Pseudotumor cerebri often presents with chronic or recurrent head pain. Thrombosis of the intracranial venous sinuses and also brain infarcts resulting from arterial occlusions can cause head pain and sometimes associated hemorrhages. Temporal arteritis causes bilateral or unilateral temporal or generalized dull headache in elderly and sometimes younger patients. Claudication of masticated is an important symptom. Patients often complain of a painful, tender face or scalp. In some cases, there is knobby, thickening, firmness and or tenderness of the temporal artery on the one or both sides. The low-grade fever and muscle and joint pain of the polymyalgia rheumatica often are indications with the temporal arteritis. Usually, the laboratory workup is being benign except for, in most cases, a substantially elevated erythrocyte sedimentation rate. When the temporal arteritis is suggested, treatment with steroids should be initiated quickly because it can prevent incipient retinal infarction. Once steroids are administered, the temporal artery biopsy can be carried out. However, this biopsy should be deferred until the testing has documented that the temporal artery to be biopsied does not supply the brain, as may occur when there is a significant occlusion of the ipsilateral internal carotid. Treatment with steroids usually continues for months or longer. The dose is tapered by using bed pain and the sedimentation rate as guides. In most instances, the headaches do not require diagnostic tests. In patients with the chronic head pain, associated symptoms and the temporal patterns of the recurrences are the most important diagnostic clues. This much for today. I will come with the next slides, next portion on next day. Thank you.